fat underneath, so then they're at risk for
Tearing, rashes,
Yep.
everything.
So that's a huge piece of it.
Especially with pressure sores in their bottom. And I mean, everywhere you get a pressure sore, but
Yep. So, I mean, because that's what, that's where the pressure ulcer is gonna develop, is over the bony prominence. So now you've lost all that subcutaneous fat that they did have, and it just even hikes them up that much higher. In a patient who is demented, who's responsible for repositioning that person? I swear to God, this was a question on your 250 exam. You guys argued with me over it.
With the nurse.
The nurse.
not the tech?
Well, no, I mean, from the standpoint of, let me think. The question in 250 was the patient didn't want to turn, so we didn't turn him. And people's answer was, well, it was his right. It was his right, and he didn't want to be turned. So then I'm just challenging you guys to think about all the elderly folks that we are responsible for, and how many of them have told us no. They don't want to go to the bathroom. No, they don't want their bath or their shower. No, they don't want their poopy pants changed. And, it's us. It's on us.
So do we kind of like step over their rights in that way? Like just in that sense?
Because it's for the good. It's for the good of the patient. Now, I feel like there needs to be like a conversation with the families. I mean, I think they need to know, he tries to beat us up when we change his poopy pants, so that they know that that's going. But I can tell you that if a demented person got a bed sore, I think the question was, the family is threatening to sue the nursing staff. What do you think about this type of situation? And it was like, he had a right not to be turned. No, they lose it. Once they lose it, they lose it. If they cannot move themselves and reposition themselves, we are ultimately held responsible for that.
So whose job is it to make the decision that they are not able to make their own decisions? Because can we as a nurse make a decision that you're demented and chart that? Wow, okay.
I don't know that I would use the word demented, because that's kind of a medical term, but I would say patient extremely confused today, combative when nursing staff tried to assist him to the bathroom. He was incontinent of urine and bowel movement, and it took 3 people to clean him up due to his trying to strike out and hit the nurses. So what am I saying there is it's documentation. That we have it backed up, because any type of surveyor who's going to look at a situation is going to be like, if they were incapable of toileting themselves, it's on us. So they can't reposition themselves, it's on us. And I think that in your long-term care facilities, that is where a lot of the care conferences, where there's that dialogue between patient, family, and staff. Because I think a lot of times the family might live in la land, maybe not wanting to believe that their person is that demented. So it's all about documentation. Okay, I feel like that's, again, we're responsible for repositioning them. We're responsible for, all those things that can happen with the immobility piece. That's on us. Get them up, get them walking, whatever. Okay, so we kind of sort of talked about this next one, and I think this next section is CHF. Is that what comes next on your test, ma'am?
Yes.
Okay. And I said you need to be able to know the difference between left-sided and right-sided heart failure. And that shouldn't be anything new. You guys were able to tell me, with that left-sided, we are seeing lungs. We're seeing shortness of breath, wheezing, fluid on lungs, dyspnea, and so forth. There was a fun little there's a picture I thought so cute. One of their mnemonics. I thought I had both on there. Oh, this has the stupid envelope again. I heard something.
It says it's on.
There it comes.
There it goes. That's what I had pulled up.
It's like in the movies. You're about to turn on the TV. Trouble breathing at night. Cough, crackles, wheezes. Tachypnea, tachycardia, fatigue, all of these things, confusion, orthopnea. And he's kind of trying to sit in an orthopnic position there.
Is that tripoding?
Tripoding. It is. So then your other one, of course, is this one, where you have the core pulmonale, I don't know. To me, I just think about fluid everywhere. They'll have the distended jugular veins, weight gain dependent edema, enlarged spleen, liver, ascites. This is somebody that may be getting a paracentesis because they just can't handle how much fluid they're carrying around and it won't come off, no matter what diuretics they use. I'll leave that up there, but I don't think I probably won't just put anything else up there. So, so I believe that we talked about, there's your questions.
I was just about to get my phone out.
I wasn't fast enough. Oh, let's turn it off. Yes, I'm sure. Thank you. 10,000 times later. Ah, funny. So right versus left, which we did that. The nutritional components and the restrictions is gonna be the low sodium diet. We know that we don't want the salt substitutes because they're high in potassium and can end up getting them in trouble. What would you expect to see? Assessment findings if exacerbation present. I think that was everything that was on those two slides. And I also think that we talked about patients are taught like to weigh themselves daily at the same time and to report, I think it's a 3-pound increase in a week. I do get those phone calls and I'll weigh yourself, or are you having an increased trouble breathing? Because these are people who struggle all the time, right? It's just worse. And we'll do meds separately. COPD, nursing considerations and responsibilities. Help a parade. I think that we did a really good job of, literally like there are answers to these questions on those slides.
Like in Joanna's slides?
Can you share your screen?
No, because I have the test map up. I don't have the test map, I have the test up.
Oh, okay.
We don't see her screen either.
Yeah, they don't get to see it either. I originally had the test map, do you have that?
No.
If you, can somebody ship that to her?
Yep.
I sent out to you guys in emails. But before I go on with
So-
What?
Like Joanna's and Esther's and yours.
Esther sent us hers. I'm not sure about.
Jessica, so I had gone into, just Google Images, and I typed in right and left heart failure, and there's like these cartoon depictions of the two different type of symptoms, and that's what I had shown them. And so then I said, I just went through like 5 different answers that came directly off of those slides.
Oh, so not like the ones we've been doing in class.
It's the same, they're the same. Heart failure is heart failure, left is left, right is right. So, yeah. What you got in class is it's just that much more supplemental. So I feel like whether we're taking care of somebody who is CHF or taking care of somebody that's COPD, one of the huge pieces, how do we want to structure our care? They're admitted with exacerbation. Whether it's COPD, can't breathe, CHF, they can't breathe. How do we want to structure our nursing care to allow for
I know with COPD, the oxygenation is 88 to 93.
absolutely in general, so that we can keep those SATs in that range for your COPD.
You like treating the symptoms?
When I say structure nursing care, that's not being helpful enough. Think about going into that room and what you do in that room.
Check their vitals.
Do you just keep messing with them and messing with them and messing with them, in and out, let's get up, let's
Do
go
like
down?
cluster
care?
care.
It's the whole cluster care mentality. So that translates in my mind into an older person that, adequate rest periods. They might have physical therapy. Well, they need a bath today. Those are 2 huge things. And both could just wear somebody out. So it would be allowing them that rest period before you go on to that next activity.
So you want to cluster the cares up. Okay.
And be done, cluster, be done. Do what you can do, and then give them that rest period. To me, like morning cares would be morning cares, and then I leave them alone until they can call me back in.
So this is a weird question, but when someone's got like heart failure, do you encourage any kind of light exercise, or you just like the heart shot, forget it?
I think that, they're going to absolutely want them moving, but I think that it's not excessive in any way. Because they could actually decline while they're in the hospital if you don't have them up. So they're still gonna say, you guys take care of these folks, get up in the chair, TID. That's their order, that's the limit of their activity. So I think that it's just minimized, in my opinion, based on what their current condition is. We've had patients that make them dangle. Oh, they dangle today. Ooh. So I think based on what they can do. When we talked, remember we had a really good discussion about how a COPD person's going to present. You can kind of pick out your COPDers in your crowds. What makes them special? What's a look that they have that you and I don't have? I don't think I have it.
Edema? No.
I'd say that's more your CHFers, not your COPD.
Yeah.
See, to me, like your COPDs, they're skinny. There's just nothing to them because they work so hard to breathe.
So it'd be like the purse split.
They could be doing that. It has something to do with a 2-to-1 ratio that they don't have. You and I have a 2-to-1 ratio?
Of inhaling and exhaling?
2 to 1.
Oh, like barrel chested
Oh,
and stuff?
yep.
Okay.
So a person with COPD, it's going to be like a 2 to 2. They're gonna be just as wide this way as they are this way. And it's really weird because they could be skinny on bottom and still have that. To me, I can tell that it's disproportionate. I mean, I feel like I see it often. When people are not bundled up in their coats. So we talked about, we're just happy, what if we can keep these SATs above 90? Life is good. And we know that for COPDers, you cannot turn up the oxygen because they will retain the CO2, which will drive down, it will depress their respiratory system even more, and then they're coding. So a little bit can go a long ways. One of the concepts that I've ran into several times with testing scenarios that trump the assess question, the assessment piece. Because we know with the nursing process, you always assess, you reassess, you assess, you have all these different ways of, that they use the word assess, without actually using the word assess. It'd be like what they're doing is assessing. But there's times when action is going to trump the assess. So we're thinking about breathing. What action do you think I'm talking about?
Putting oxygen on?
Oxygen. What about their placement? You remember me telling you back in 250 about the portable chest x-ray people that put my patient flat on her back, and the doctor comes walking in and he tells me to call code because she wasn't breathing? So whenever there's a situation where you can get them elevated, that is always gonna trump an assessment piece. I remember 250, being in clinical with them, and they couldn't find their nurse, but they could find me, and this patient's SATs were like 87%. I walk into the room, she is bent over halfway, of course an older lady. You know what we did? What did we do for her?
Sit her up.
Set her up. Brought the head of her bed up a little bit, and she recovered. We didn't need to do anything with that assessment, with that oxygen levels. So that's there. If you see that, look at it really closely. If it's an easy fix, fix it. Do you understand, especially when you look at that core, do you guys understand what core pulmonale is?
It's right-sided heart failure.
Damage to the heart because of the,
Enlargement of the right ventricle?
so I think the piece there when you think about, the core pulmonale is how, how interrelated COPD and heart conditions are. That one is going to make the other one worse. COPD can put somebody in heart failure. I'd like to know if you guys have made that connection or not.
I feel like I've never heard the word core pulmonale before.
She summed it up beautifully,
Okay.
the right failure.
Right.
But it's from the, yeah.
But isn't it right-sided into the body, and then left is into the lungs?
I know, I didn't make the rules.
That's so confusing.
I think just in general, if you can associate cardiac disease and COPD as they are like codependent on each other.
So is core pulmonale a phrase when talking about COPD patients? Or is it just in general?
In general. It would be a COPD or is starting to decline. And they're gonna look at the heart. So heart will never cause COPD.
But COPD
COPD
can cause.
heart.
Does the core mean heart and pulmonale mean lungs?
So COPD can cause heart will never cause COPD. Heart just causes heart. They can't breathe because of fluid. There's another answer that was on the board. As far as like, what would you teach your patient to report? They came in for exacerbation of whatever. What would they need to report back? Well, the whatever would be heart failure. You know, what would you report back? Again, the weight gain. My gosh, I mean, some of these people and the fluid that they carry is just mind-blowing to me. My husband, like he would indent, I'm not kidding you guys, that much. That he would have that much fluid. He looked huge, he looked fat. And I'm like, I said he can't even wear he's gonna wear his pajama pants home because his jeans won't fit him because he had so much around his belly and his thighs. And then one day, he magically digressed. Talked about that one already. Okay, moving into pain. Pain. What is, my gosh, we were just talking about this at 2:50. What is the nurse's responsibility as far as you have a patient that had surgery, we know they're gonna hurt, we know that the doctor expects us to get them up and out of that bed ASAP. We don't want pneumonia, we don't want DVTs, we don't want pressure ulcers, we don't want constipation or urinary retention, all of that stuff that comes with immobility. What is the role that we can play in getting them up and going?
Well, can't you give them pain meds before?
Pain medications, absolutely.
How long before?
30 minutes.
30 minutes?
30 minutes, yeah. And I'm talking probably more PO. It might be morphine, it might be IV, but the expectation's gonna be a little bit different. You know, usually it's PO. And we wanna get them switched over just as quickly as we can. We know that using their incentive spirometer can make them cough. We know that we have this thing called turn and cough and deep breathe, and that makes them cough. So even like to try and give them pain control for those symptoms, because we need you to cough so that you don't get pneumonia. We praise them. Good job, you did awesome. How many people, have you guys ever had that? You're having them do their incentive spirometer and they have to stop because they're coughing. Like, yes, good job. Proud of you. Again, we talked about this in 250 today. The most reliable indicator for assessment, reassessment of pain is always gonna be the pain scale. Lying quietly, reading a book, napping. That's not it. When it's the best indicator, it's gonna be the pain scale. Just like, what's the best evaluation of fluid volume? Daily weights. Yes, we know intake and output are out there, but we care about the daily weights. Just apply that to your pain scale as well.
So what if you have a patient that they're reading in bed quietly, whatever, but then they say they have a 10 out of 10 pain?
We believe the patient's pain is what they say it is. So then we look at the MAR and we give them their options of what they might want. and go from there. Well, documentation again is really important. You know, part of like them getting ready to go home and you know, like going through the rehab of like the day after surgery or whatever, the nurses are like, oh, the doctor's gonna want you off that morphine. Because we can't send you home with morphine. So this will probably be the last dose of morphine you get. We're gonna get you switched over to oral pain medications. And then when they're looking at us like they hate us because we just delivered this news to them, then we tell them this great news. Oral pain medication gives you longer pain control than IV. It just does. To me, morphine, you're hurting like crazy, you're stoned, and a short time later, you're already kind of coming back down. Maybe 2 hours, but still, compared to maybe 6 hours. So what I tell them about the oral pain medication, it's more like this. It doesn't have that crazy peak like the stronger opioids do. What can affect a person's perception of pain?
Culture.
Absolutely. Culture, and there's one other thing. I'll say to my caller, I said on a scale of from 0 to 10, with 10 being the worst you have had in your 36 years of life, where would you rate this? So what am I asking about?
Like experience.
Their previous pain experience. I diagnosed my brother with a kidney stone over the phone last week. I was so very, very proud of myself. I'm literally asking him questions. I knew he was in trouble. For his wife to call me, I knew he was in trouble. And then when he said 7 to 8, in my mind, I did the translation. He is a runner. He knows pain. He ignores pain. To me, he says 7 or 8. I'm thinking he's a 10 plus. I said, go to the emergency room. He had a bouncing, maybe 3 millimeters. He said it was 3 millimeters.
So culture and then pain experience, what are those two? Like, that's,
Perception of pain. Not everybody has a good experience. I mean, a bad good experience. I think there's some women who don't know pain until they go into labor, and they just flip out. I'm like, pain is what they say it is. They're just dying, and they're 1 centimeter. Oh, honey. So when you're doing your pain assessment, severity, using the pain scale is the most important thing, and then what comes next? Think about old carts. When did it start? And what's the L for?
Location.
So we want to pull out those pieces with that old cart. To me, when you're applying that old cart mentality to anything, pain or any other disease condition, you're having the patient describe it to you. But you're having to kind of give them little helpful hints. D for duration. C, again, for the characteristics, it says sharp, dull, aching, pinching, cramping. Skin. What's the connection between congestive heart failure and skin issues?
I know the edema can stretch their skin, like almost to a bus.
Crazy. Yes. What else?
Dehydration, maybe? I don't know.
When you guys are thinking about congestive heart failure, I just want you to picture in your mind big fat ankles, cankles,
I
maybe
got those.
swelling. I do on some days, it depends on how many Margarita. I'm a huge salt retainer as I've gotten older. I'm like, that's a telltale that I had a margarita. I want you to just think like peripheral vascular disease, think skin breakdown. They have so much fluid in their lower extremities and their feet that sets them up for this huge skin problem. And a lot of them, it's like, oh, if they don't have problems down there, they don't have ulcers, it's like a miracle. So we just gotta do whatever we can, try and keep those legs from breaking down. You know, it might be getting the ACE wraps on before they get out of bed, because they can't fit into a TED hose. All right, going on to drugs. I think we start with ACE inhibitors. I sent you to page 155. If you look under, there's not one single test question about the expected pharmacological action. I don't want you to tell me how that drug works on the system. I care more about patient education, what you need to tell them to report, what the nurse should be looking for. So when you get to your prills, and you look under complications, you see cough. So cough is considered to be contraindicated. If they start coughing, we want them to stop taking the medication. It also talks about the risk of high potassium. I think to me in my brain, when I'm thinking about blood pressure and I'm thinking about the pills, I'm thinking sodium and potassium. Do you guys go there too? Because we know the sodium's gonna make it worse, and potassium and sodium like each other, and okay. So under the potassium, they say no salt substitutes. That's pretty much it. To me, when I think about angioedema, I think that could happen on a whole bunch of drugs. The neutropenia. If it's not up here at the top, it's just not quite as important.
So the biggest things for that is your sodium and then the coughing
Yes,
for your prills.
I want you to think potassium as opposed to the sodium, but yes,
Wait, what did I say?
you said sodium.
Oh, I meant
I
potassium.
thought you did. They also can have a rash. They can get what they call it, a lisinopril rash.
Like the petechiae looking?
My husband just carries it all over his body. And it will probably be there until he'll take it to the grave with him, I'm sure. Okay. That's it. Nursing actions. Monitor blood pressure. I think here, under the, that piece, let's not have orthostatic hypotension going on. Would you not apply that to every single blood pressure medicine? Change position slowly. Okay, next one is your beta blocker 162. Okay. Your ORAs. I have a big ol' asterisk by use cautiously with clients who have heart failure. It can make it worse. So if they were starting to have those signs, shortness of breath, weight gain, swelling, that is an issue, that can be an issue. I have highlighted change position slowly. Then I have highlighted and starred avoid in clients who have asthma. That is under the propranolol. But really for the most part, I'm not singling out one drug out of the OLAs. I'm not singling out one drug out of the pearls. You can apply it across the board there. Propranolol can mask the hypoglycemic effect of insulin. So propranolol would need to be cautious in the whole, if they were diabetic. Do not avoid sudden changes or orthostatic hypotension stuff. Seeing some repeat stuff here. Okay, then I go on to the calcium channel blockers, but also include your verapamil and dilantin, cardiazem. I can't say the other one. 158. I gotta go backwards. Calcium channel blockers, I have the word grapefruit written in red and a circle and a line through it. Your book only picks on it clear over on the nifedipine. But Sarah said she just said grapefruit doesn't play nice with anything, especially when we're talking blood pressure medicines.
So no grapefruit.
Then I'm going over, I mean, this is all good stuff. It's not like don't read it. I want you to read the whole thing. But over here under the verapamil, it talks about that there is constipation associated with verapamil. So increase fiber foods and oral fluids if not restricted. Back in the old days, we would take a Procardia, nifedipine, and we would puncture a hole in it with a needle, and we'd squeeze it and give it to them sublingual. I don't know if they do that anymore or not, to bring down that super, super high blood pressure. So interactions, grapefruit juice, client education, fiber. Moving on to nitroglycerin. I knew this about nitroglycerin. I think this will be on your NCLEX when you take it, but I had forgotten it. Number one side effect of nitroglycerin is, and I'm not looking for bottoms of their blood pressure, headache. I knew it. I think I was probably tested on it, but I had forgotten it. I don't know if it lowers it rapidly enough that like it's too big of a change too fast. We don't care. Take Tylenol. Oh, again, orthostatic hypotension.
What? Oh.
Oh, you're thinking
What page you were on?
173.
I was gonna, okay.
Treatment of acute angina attack. When you actually are putting it on and taking it off, have you guys taken care of somebody that has the nitro paste and the little paper, and you put the nitro paste on the paper and then you tape it to them? The biggest thing with that is that the nurse wears gloves, because what happens if you get it on your skin and you don't have high blood pressure? Hello, Tiffany. How are you? Did you hit your head? Right? So to be careful with that. Also with the paper and the tape, which seems so old-fashioned, we rotate them because it can irritate the skin. But usually they're off for 12 hours. So they're on in the mornings, off at nighttime. Is usually what they do with that. All right. I am flipping to Jackson. Jessica, you keeping up with this? I hope You are. Number one side effect of ditch toxicity is what is it?
Nausea and vomiting?
Nausea and vomiting. Anorexia, of course, could accompany that, so I have written in red by client education, anorexia. Probably just feel too crappy to want to put anything in their stomach. The second most common side effect would be blurred vision, yellow, green, or white halos around objects. You are learning, I was looking for what they're actually gonna put in a ditch level in this book because they have the potassium level there. 2 different pages, they have the same potassium level. Oh, now we're to 3 potassiums.
What page are you on?
I'm looking at 168. What do we want the ditch level to be?
0.6 to 1.2?
I think in the big scheme of the world, we want it less than 2. If that kind of helps you remember. Remember I was talking about NCLEX tricks? And it's either less than 2 or less than 20 is where most of the drugs fall into place.
So if it's less than 2,
Yeah.
we should be good.
Good. I was looking for them to give us an actual number in here, but they can't do that. I had never heard of this before. I did not pick a question with this answer, but I think it could be on ATI, because we're doing this farm stuff for your ATI scores. For excessive toxicity, you can give digoxin immune fab, F-A-B, never heard of it. Can be used to bind digoxin and prevent absorption, or charcoal. But this digoxin immune fab, I can't believe that 4 different times they have this potassium level. And let me tell you what, it has not changed. 3.5 to 5, 3.5 to 5. I find errors actually care enough to let me submit them to them. Oh, you know this one, check pulse rate. Hold if less than 60. Theophylline. Has anybody had a patient on theophylline? It's such an old-fashioned drug. 162, 163. Why am I not seeing my drug? My page numbers are wrong on that.
I think so. That's why I didn't ask.
Yep. Theo is on 132. I think I'm sharing this document, so maybe if I correct it on here.
Is this a pill or an inhaler?
This is a pill. So under the methyl xanthines, this is your COPD. It's got COPD written all over it. You might see it as Theodur. You can see under that nursing actions, it's 5 to 15. So you can imagine 20 then would be extremely toxic. Again, falls into our 2 and 20 mentality. I have written in red, monitor for elevated heart rate. Dysrhythmias and seizures for toxicity. have that it interacts very poorly with caffeine. Caffeine increases CNS and cardiac adverse effects, dysrhythmias, if taken with theophylline. Caffeine can also increase theophylline levels. So the theophylline is kind of like Reglan. It's kind of in its own little special class there. Have a contraindication. Ooh, we don't give it to people with pregnancy. Periodic monitoring of blood levels is needed. Report nausea, diarrhea, or restlessness, which are indicative of toxicity. And I have an arrow pointed to elevated heart rate and restlessness. We're to our last one. Aspirin. Did you guys know that ibuprofen is on the beers list? Okay.
All the NSAIDs, right?
Seems like the aspirin for the low dose, like the 81 milligrams for the possible prevention of everything. Let me see. I think the biggest thing would be the toxicity again, and here would be like the tinnitus is a sign. The biggest thing that you have to remember is that it is an anti-prostaglandin. This goes back a long ways. So if we know that prostaglandins do some really great things and they do some really crappy things. Prostaglandin is released when we're injured. So that is, prostaglandin is partially what's responsible for the inflammation, the pain, the fever, all that kind of like yuck stuff. So if we block that, that's how we get pain control, that's how we get fever control. But one of the big problems is it also blocks the ability of the stomach to protect itself. It messes with the gastric mucosa and affects the healing natural properties that are supposed to be there. That was a positive that prostaglandins do. So these folks have a higher risk of like a GI bleed, stomach ulcers. So we really don't like them taking it. Oh, I think I just threw in Rye syndrome more for your pharmaceutical test than anything. Where is... How does it work in the event of a heart attack? What does it do?
Doesn't it make like the cells like slippery, right? So that they can't like clump together.
You're gonna have a harder time creating a clot. So if there's a clot that has happened because of whatever, years of smoking, fat intake, who knows? But the pain, of course, is being caused, the damage is being caused by the blood not being able to get past that clot. So if we can dissolve that, or get it to where it's not, no, you are not gonna stick together. It could return blood flow to that heart muscle. Damage to the gastric mucosa. If they smoke or drink, it's gonna be even worse. Big risk for GI bleeds. They have to take it if it's the drug of choice. It suggests a PPI or an H2 receptor, so that's your Zantac, your Prilosec, your omeprazole. Osteoarthritis. NSAIDs are the the first line of therapy for rheumatoid arthritis. Tylenol is the #1 frontline medication for osteo. arthritis. It doesn't always work that well. Sometimes they will do opposite, but as far as what is considered the first line therapy, that's it. But guys, that's all I got. Looking here. How would you instruct a person to take their nitro? Oh my God, I'm having chest pain. Give me my bottle. I need my nitro bottle. Okay, now how am I supposed to take it?
Under their tongue?
Is it under, like,
Is it under your tongue?
Sublingual. How often can they repeat it? How often can nitro be repeated?
I'm thinking if that happens, you need to get to the hospital, right?
So let's say that they have a diagnosis of chronic stable angina. This is not a first time they've actually been given this diagnosis.
one tablet maybe used every 5 minutes? That's a
If
lot.
it does not relieve by that third tablet, they want them on their way to the emergency room. They actually want them on their way to the emergency room, but I'm not gonna get that picky. They have to take the third one. Because now we're worried about, are we bottoming out of blood pressure? Is it a true, did it switch from from chronic to acute? So how does it work? How does the nitroglycerin work?
It causes vasodilation.
It does. So with the vasodilation, then we can get that return of the blood flow to the heart. Do you guys know that morphine does the same thing? Allows those vessels that are so tightly constricted to relax. Once we have that relaxation, the blood can start flowing to the heart again. So that is why morphine is often the first line if we don't do nitro. Theophylline, aspirin, calcium channel blocker. I think you guys should be fine. Do I do? It'll be on respondents. There's 41 questions, but it's probably just gonna be a 40-point test. So that one would maybe give you guys a little jiggle room.
Are the questions all on one page, so we can scroll them down?
One at a time.
Can we backtrack or no?
I think that would be nice of me. I know you guys have a lot on here. I think I have to go here. Here. You're still gonna get one at a time, but I took away the prohibit after.
Thank you.
Anything else? Jess, I'll show you. Maybe you already knew what I was talking about, but these pictures are found on the, when you Google heart failure and images. And I was saying that a lot of the answers are found in these right here. Jessica, if you don't have any questions, I'm going to end Zoom.
Okay, I don't think I do right now.
I'll see you tomorrow. Thank you, I'm glad you were able to join us.
Hi, thank you.
So there is the Zoom recording. The way that you would get to that is you go to our class and there's, you click into our class and there's a Zoom link and you click on that link and it will take you to the cloud.
I don't know why the core pulmona is really giving me a hard time.
I mess it up because I get it confused with cardiac tamponade.
Is that opposite?
That's like a life-threatening,
Okay.
the doctor's gotta get him to surgery and they're gonna crack his chest and get the bleeding stopped.